Hi, good day, everyone. Welcome to the Ifso Channel Club. My name is Ong. I'm an upper GI and behavioral surgeon from Singapore. I'm also a member of the Ifso Communication Committee. Today, Channel Club article chosen is the best article of the October issue published in University Surgery. The title of the study is The Markers for Major Complications at Day 1 Post-Operative in Fast-Track Metabolic Surgery, Updated Metabolic Checklist. We are honored to invite Dr. Judith Hart from the Netherlands. Judith is from the Franciscus Hospital from Rotterdam, the Netherlands. So she will be presenting about her study. And then after that, all of you can join us in the actively for Q&A sessions. The Q&A session, you can type the Q&A box in the Zoom. And also this presentation of the General Club will be recorded and it will be available to all the Ifso members at the virtual Academy of the Ifso and also on the Ifso YouTube channels. So please join us and then welcome Dr. Judith Hart. Judith, please.
Thank you very much. Thank you for having me, and let's start with the presentation. Hello everyone, I'm Judith Hart from the Franciscus Hospital in Rotterdam, the Netherlands, and I'm also a PhD candidate at the Erasmus University in Rotterdam. And I want to present to you the article Markers of Major Complications at Day 1 Postoperative in Fast-Track Metabolic Surgery, an Updated Metabolic Checklist. We did this research with our research group in the Franciscus Hospital, and I'm very honored to give you this presentation today. And I want to thank the Ifso and the obesity surgery to give me this opportunity. So I want to tell you something more about why we did this study. In this study, if we talk about fast track protocol, we mean the enhanced recovery after bariatric surgery. I think you are all familiar with it. A few important subjects from this protocol is the early mobilization postoperative, but also stimulating patients to drink water, just oral intake, without that they are dependent from IV fluids. And another important point is the lighter narcosis, for which the patient can recover faster after the surgery. So because patients recover fast after surgery, and it is standard in our hospital that the patient stays overnight, just for one night. But this means that your window to detect some complications is very small. And even in the last few years in the Netherlands and also in our hospital, we started also doing bariatric surgery in daycare, which means they even can go with discharge at the same day. So your window to detect a complication, if it would develop, is even smaller. However, it would be nice if we had a tool in which we could detect and still could let the patient go with discharge this early after the operation. Another reason why we wanted to use a checklist is because in our hospital, the young residents walk the ward rounds in the morning or before discharge. But this also means that it sometimes can be difficult for those young residents. We are a training hospital, so they know when to call the surgeon, but sometimes it's very difficult. And most of all in the bariatric population, in which the patient can be very ill, but from the outside sometimes you don't see it, it's a very difficult decision to make. So for the young residents, it can be difficult. Can a patient go with discharge or definitely not? Or should I consult a surgeon? Which tools do I have to know for sure what to do? This was one of the reasons also why we started to using a checklist, but also because in other surgical fields, it was found out that patients with a good checklist, which would go home, would have less development of complications. So we also wanted to try a checklist in the bariatric population. So we did a study in our hospital in which only patients with a primary bariatric surgery were included, and patients eligible by the Ifso criteria were included, and patients with which reason at day one the checklist wouldn't be filled out would be excluded. So this is the checklist. In total, it consists 14 points, and it's separated in 3 parts. The first part is the anamnestic part, in which we look at the FAST score. So that's the pain score from 0 until 10. 0 less, no pain, and 10 the most worst pain ever. We also looked at the nausea score, which had a score from 1 to 4. If they already could drink some fluids like water, but also if they mobilized, and we don't mean just to the bedroom, but really did they walk on the hallway to look if mobilization would also could go well at home. They even try some stairs with the physical therapist, and if the patient is willing to go home. So does the patient feel confident to go home? Then we look at the physical examination. We look at the abdominal pain, calf pain. We look, of course, at the heart rate, oxygen saturation, but also at the drain production, if the patient had a drain during surgery, because most of our patients don't receive a drain. And we look at the temperature. And then we also look to some laboratory findings, the hemoglobin decrease, the white blood cell count postoperative, and the C-reactive protein postoperative. The hemoglobin was the only marker that was also analyzed pre-operative, so you could really look at the decrease. You see in the right column the cutoff point. So this is the threshold. If the patient goes over this threshold, it would score 1 point for each item. And in total, it could score 0 points or 14 points. This checklist was filled out at day 1, so just before discharge. It would be filled out by the resident, but also a part of the checklist would also be automatically already filled out, like the heart rate scores, because it's already in the electronic patient record. And then right now, it was like that the checklist would already give a negative advice if one of those thresholds was reached, so very fast. And the negative advice meant that the surgeon should be consulted. The positive advice meant that the patient could go home or go with discharge. But if it got a negative advice, you should consult the surgeon. Then, of course, the answer could still be that the patient could go home. But it could also mean that the patient should get some extra diagnostic tests, like a CT scan or extra hemoglobin monitoring. But it could also, of course, mean a reoperation. Then our primary outcome was major complications. We used the Clavin-Dindo classification. If a patient had a Clavin-Dindo classification of 3 or higher, it was classified as a major complication. And if it was lower than 3, it was classified as a minor complication, which is one of our outcomes as secondary outcomes. And then we also looked at readmission and unplanned revisits. And the unplanned revisits could mean visits at the ER or unplanned at the outpatient clinic. So not the planned visits. We included in total 1,589 patients in the study, from which 871 patients received a sleeve gastrectomy, 551 received a Roux-en-Y gastric bypass, and 167 received a 1 anastomosis gastric bypass. From those patients, 62 patients had a major complication, which is almost 4%. And then 133 patients had a minor complication, and 71 patients had a readmission, and 170 patients had an extra unplanned revisit. And this study was conducted from 2018 until 2021. So if we look at our primary outcome, here we see that if the patient had a major complication, 90% of those patients had also a negative advice for early discharge. In the patients without a major complications, they still got a negative advice in 48% of the time, which means that the positive predictive value is low, 7.1%. However, the negative predictive value is 99.2%, which is very high. What does this mean? It means that if a patient had a negative advice to go home, it had a significantly higher chance to develop a major complication with an odds ratio of 10.1. If we then look at the area under the curve, you can see at the right, this was for the whole checklist, so you could have 0 to 14 points. The area under the curve for the checklist was 0.8, which was significant. And we wanted to look, now already the checklist went off if you had just reached one threshold, but what would be the optimal points you should reach before the checklist would go off? And at 3 points, the sensitivity was 62 and the specificity was 82, and this was the best cutoff points. So if we then look at some individual markers, we of course also looked at the differences in baseline characteristics between patients with and without a major complication, and we corrected for the differences. And then these individual markers were still significantly different between those groups. And we saw that patients with a major complication, at most of the time, no oral intake, no mobilization, were less willing to go home, at a higher heart rate, had more decrease in hemoglobin, and had a higher leukocyte count. And if we then zoom in on the heart rate, because we wanted to look for all the individual markers, if the area under the curve could reach above 0.7, but this only happened for heart rate, which had an area under the curve of 0.75, which was significant, and would have the best cutoff point at 80.5 beats per minute, with a sensitivity of 74 and a specificity of 68. This is not very high. So heart rate and hemoglobin were significant. So we were thinking, from those 62 patients with a major complication, what were the complications? And we saw that most of these complications were a hemorrhage. So in 38 patients, we saw the major complication was a hemorrhage, a bleeding. This is 61% of this group. So we also did a sub-analysis between patients with no hemorrhage and patients with a hemorrhage. And we saw again almost the same significantly differences for the individual markers. But also here the nausea scale was significantly worse in the group with a bleeding. So yes, and the same is again for oral intake, mobilization, willingness for discharge. And if you look at heart rate, you see that if you don't have a bleeding, the mean heart rate would be 77 beats per minute. But if you patients had a bleeding, the mean was 95. And this also was again for hemoglobin postoperative, the hemoglobin decrease and the leukocyte count. And of course, again, also the advice was significantly more times negative in the patients with a bleeding. But if we then also separated these groups, we again had the same group for bleeding, but we had also some patients with a minor hemorrhage. So patients that received tranexamic acid to control the bleeding, or were stay longer because the hemoglobin was very low, or needed some red packed cells to recover. If we then look at those patients, we have again the same significantly differences, but also the drain production here is significantly different. However, just a few patients had a drain, and of course, if you had a bleeding during the operation, it's more logical to also use a drain to monitor the bleeding. But if, for example, if you look at the heart rate, you see again a mean heart rate of 77.5 beats per minute in the patients without a bleeding. Then if you look at minor bleeding, the heart rate will receive 80.3 beats per minute, and in the patient with a hemorrhage, it's 97. So you can see an increase in some values. If we then look at some secondary outcomes, we can see that patients with a minor complication also had significantly more times negative advice. This was the case in 81%. But if you look at readmission, you see this was not significantly different. So 33 patients had a negative advice, but this wasn't significantly different between those groups. And if we then look at unplanned revisits, 100 patients had a negative advice for early discharge. However, this was also not significantly different between those groups. If we then again look at some individual markers of the checklist, we can see that in the minor complication group, so the first column, patients had more problems with nausea or vomiting, had less oral intake, had also less willingness to go home, had a higher pain score, also had a lower hemoglobin and a higher C-reactive protein. So some minor complications really needed some medication or supervision. However, also part of this group had more problems with being nauseous or vomiting, which can also be normal after the operation. However, these patients could be more insecure, and we try to look at these results and then manage this better per-operatively. So advise patients more about what would happen after surgery. And then we saw less minor complications. If we then look at the individual markers for readmission, you can see that the hemoglobin was significantly lower and the C-reactive protein was significantly higher. And if you then look at the individual markers for patients that had unplanned revisits, you see most of the times they had higher pain scores and were less willing to go home. So here again, we had to already before the operation, just explain more to the patients how to manage the pain and what you can use. And then we already also saw less patients coming back to the outpatient clinic and to the ER. So in conclusion, this checklist can be very helpful. However, the positive predictive value is low, is 7.1%. However, the negative predictive value is 99.2%, which means that if a patient can go home on day one, it wouldn't develop a major complication in most of the times. So the question is, the surgeon can be called sometimes too much. However, you know that if you use the checklist and it gives a positive advice to go home, it is very safe to use. And if you look further, we saw that the patients with a hemorrhage had significantly different values, and the checklist was also significantly more negative for those patients. And if you then look also at the literature, they also tell that the delta heart rate would be very interesting to look at. We didn't use this in the checklist. However, we analyzed this because we had a perioperative heart rate. So if you see here in the first row, you see the difference between patients with a bleeding and without, and this is just a post-operative heart rate. You already saw it earlier. And then we compared this to the heart rate before the operation, and we saw that patients with a bleeding had a delta heart rate which significantly increased with 19 beats per minute, and it decreased with 0.2 beats per minute in the patients without a bleeding. So this is a very big, significantly difference. So if you have a suspicion for a bleeding, it's also very useful to use the delta heart rate. For hemoglobin, we looked at the same, also at the delta, and then we also made a cutoff point for the patients with a bleeding, and we saw that at the cutoff point of 1.1 millimole per liter, the area under the curve was 0.9, which is very high, and had a sensitivity of 87 and a specificity of 87. So if you have per-operative hemoglobin, because of course then you should have also a per-operative hemoglobin, you can compare it to the post-operative hemoglobin. And if it then reaches the threshold of 1.1, it can really be suspicious for hemorrhage. Then we were a little bit surprised because we had expected before we did the trial that the C-reactive protein probably would also be significantly different between the patients with and without major complication. However, this didn't occur. Then we were thinking which patients normally have an increase in C-reactive protein if they have a complication. And the first group we, of course, were thinking about are the patients with a leakage. Then we looked out, we searched out, and we saw that just 9 patients had a leakage. So this is a very small group. And if we then look only at these patients, we saw significantly higher C-reactive protein. However, of course, these are very small groups, so we cannot really conclude something about this. But if you compare this to the other group, which had a mean between 20 and 25 C-reactive protein after the surgery, this is way higher. So if you really have a suspicion for a leakage, it still can be useful to also look at the C-reactive protein. And then we also want to look at some markers with you that we were doubting about if it could be valuable or shouldn't be in the checklist. We also looked at cough pain, post-operative. However, it doesn't mean that immediately after the surgery, a patient will have complaints and then also would have a venous thrombotic events, because this can happen in the first 3 months after surgery. So it's probably not the most sensitive marker to use just at day 1 post-operative. We also had the same problem with drainage, because if the surgeon decides to use a drain, there's already some complication during the operation, because we don't standardly use anymore any drains in our patients. And if you would do standardly use a drain, it can also lead to extra complications like infection. So in our hospital, we almost never use a drain anymore, only if there is an indication during the operation, but then the patient already had a complication and of course has a higher risk to develop problems after surgery. And then one other point we wanted to talk about is that not every patient has the same operation time the day before. So some patients were operated in the morning and some patients were operated late in the afternoon, but they all had the measurements the next morning. So the time interval could differ, but we corrected for it. And we saw not very much differences anymore, just like it was before. So it was still significantly different. However, we didn't do this in the study. And I think it just explains more that even if there is a small time between the surgery and the next morning, already the measurements, for example, just 12 hours between, it still can be useful to collect those items. And can be used. So this is also very useful for daycare surgery. So altogether, in conclusion, the checklist can be used for the young residents and for the bariatric patients to go very safe with discharge. But of course, if the checklist has a negative advice, the surgeon probably would be consulted something too often. But we think that it's better just to call sometimes too much than you wouldn't use a very safe checklist. So it is very helpful to use this. Thank you very much for listening to my presentation. And I also want to tell you something about the next Ifso World Conference, which is in September in 2024 in Melbourne. And I think it's very great if we all go to this very nice conference so that we can meet each other again and listen to each other's presentations. Thank you very much for listening.
Okay, thanks Xxxix for the wonderful presentations. Yeah, so I think now the floor is open for Q&A. Please feel free to type any questions to Judith about her study in the Q&A checkbox. First is the thanks by Dr. Atta for good presentation. Congratulations again, Judith. Okay, before people start asking the question, I have a few questions for you, Judith. So can I check how were the components of the checklist, right? You use to derive, right? I think it's the 14 items, right? And 0 to 14 is the checklist, right? So how do you derive this? Yeah, thanks. Okay, again, Dr. Bara says that the great presentation show us the checklist again. So maybe I'm not sure.
Yeah, I don't have the presentation open here. I cannot open it here. But if you go to my article and you would look at table, I think table 2, if I'm correct. Oh, table 1. Then you can see the cutoff points and the items. And as I told you already, it's subdivided into 3 parts. And it's mostly came together just on the surgeon's view. So the surgeon was going by the ward rounds, and some points we saw back very much times, and then we decided to include those in the checklist. And of course, I think from the literature, it's we know that a higher heart rate above 100 is very significant for some problems or a lot of pain. So due to the literature, we used some cutoff points and by just the clinic.
Yeah, so it's mainly for the clinical decisions, right? For routine ward rounds with some of the evidence from the literature. So you put these components. So there's just happened to be 14, right? There's no magic number, right? Okay, so second question is from what pain medication do you use post-operatively?
The pain medication, yeah, that's the part of it is standard. So we start with the normal paracetamol, the normal 4 times a day, 1 gram. And then we also we don't use things like NSAIDs. We are very careful with it because you make osmosis. So then sometimes we use morphine, but we are very careful with it because a lot of patients really can manage their pain with a little bit of painkillers. And the first day, just the day of the operation, we sometimes give something more, but the next day they never need it again. So we try to be very careful with using morphine in tablet form.
Thanks. So NSAIDs is okay, right? So far your experience, any relationship with NSAIDs with the so-called leakage patients? No, right? In your study group? No. Okay, the other question by Dr. Maria is, at the moment, the checklist is not validated. Any validation of the checklist so far?
There are updates. So we used in the checklist the calf pain. However, what I already told you in the discussion, there are few patients and just 1 patient had a venothrombotic event. So I don't think it's very significant to use this in the checklist. So we decided to remove some not significant markers. And we did a separate study to the neutrophil lymphocyte ratio. And if you do the blood draw and you will look at the leukocyte, you also can calculate this. You don't have to do an extra blood draw. And that's a very good marker, probably even better than just looking at the white blood cell count. So that will probably be introduced in the new checklist. And we're going to try to make more a model in which we will connect some markers.
Yeah, thanks. Thanks, Judith. So the other things I would like to ask you is how do you decide about the negative advice, right, for checklist points? I think it's a 3 point, right? Point 3, you decided that if you satisfy as 3, it is for the safety reason because the residents are rounding, right? So you want to be lower the threshold so that it is to catch.
Yeah, so the threshold right now was just 1. So if one threshold would be wrong, it will already go off. So, but that's very early. So sometimes the surgeon was called and he was like, no, that's nothing. It's okay to go home. However, if you will have a threshold of 3, it's more significant. But it's very safe to use because 99.2% of the patients you send home, they will not have anything. So a very, very small part is coming back with a complication. But I think that's the normal clinic. It's maybe even something higher, but it's almost the same. You can never have no patient sent home, and sometimes you have a complication. So it's very safe. However, they call the surgeon sometimes too much. But I think that's better than they go
safer
home.
than, yes, correct. Yeah. So I think that as far as the checklists are fulfilled, means that it's very, very safe to let them go home. Right? If it's is deviated, then they probably call your seniors to ask for the advice before sending the patient home or discharge home. That was the strategy you apply, right? Okay, sounds good. Okay, there's one question about from Dr. Surendra about do you use Saga for reversal from anesthesia? Do you have any idea about the reversal for anesthesia?
We have a standardized protocol. I am not an anesthesiologist, so I don't know really what the grams were, but I know we follow the ARAPS protocol. It was published in, I think, 2014, and there are all the specified medicine and the grams are shown. But it's standardized for all the patients.
Sure. So standardized across using the ERAS protocol, right? ERAS, the bariatric surgery protocol, and follow strictly on the protocol, right? Okay. So the other question is, any plans to try it across the other institutions?
If we are going to expand it, the study?
Yeah.
I think you should make a model of it. So if you have a heart rate and a low hemoglobin, it should be more a prediction model. However, that's more difficult to make than how the checklist is comprehends right now. And then you have to go to an ethical commission, because then it's more like they will see it as an intervention instead of just using a checklist. But it's something we're thinking about to make it more like a prediction model.
Good. So regarding one of the questions about the checklist, I think it's available online in the Obesity Surgery Journal. I think it's October issue. And then maybe I think I will probably ask organizing the committee, if so, to help share the article link in the Ifso websites or YouTube channel or Facebook. Okay, so the other interesting question is how often are the heart rate and SpO2 measured post-operatively? Is there any continuous measurement overnight, especially for SpO2, since patients more often will desaturate when asleep? So this looks like it's because patients are obese and right, OSA, all these things, then how often are you measured? And then because of the day case, right? So is how good is your frequency to monitor the patients? Thanks.
So I think for daycare surgery, you have to be already a kind of good patient. So you don't have to, if you have problems with you need a CPAP or something, you're not you have to stay overnight. So those patients aren't included in daycare surgery. But if I just look at the overnight patients, we look at 10 o'clock in the evening, then we will do also all the measurements, and after that they're going to sleep, and of course the nurses are walking around, so they will check if everything will go okay. And then in the morning, very early, it's standardized that everyone around 7 8 a.m., all the measurements will be done again. And for daycare surgery, they will be, of course, just after the operation, you will check them. And then 3 hours after the operation, and then before discharge again. But that most of the times that those patients are already the better patients, because they are already selected for daycare surgery.
So your daycare, how many hours do you observe after the anesthesia? And then, I understand it's a good candidates, a good patient, right? And then is there any BMI cutoff point or, any comorbidity you select for the daycare? Yeah, for those so-called daycare, and how many hours monitoring before you send home? Yeah, thanks.
Very good question, because that's still, I think, a topic we are all struggling with. I think there are a lot of comorbidities that are excluded. So if you have problems with sleeping apnea, you're not included. And sometimes we even decide if somebody has diabetic, it also is excluded. And that makes it a problem because a lot of patients has these problems. And of course, if they had a thrombotic event in the medical history, that's very dangerous. Then you want to observe them something longer, or a bleeding in the medical history. And patients that are reoperated, so not a primary bariatric surgery, they are also excluded from daycare surgery. And the time, we only operate patients in the morning, because then you can monitor them longer. And most of the times they will stay until a maximum 8 p.m. So then they have to leave. And if it's not possible and the measurements are not good, then they will still stay overnight. But I think around 6 hours.
Okay.
Less.
Yeah. So in your experience, right, just I couldn't read in your papers, but I think how many percentage of those patients are successfully discharged to the daycare, or maybe I will wait for the next studies on that.
I think leakage is very low. I think in the last 10, 20 years, we are getting even more. We have practiced a lot, we operate a lot, so the leakage rate is very low.
Daycare. How many percentage of the patient has a daycare? Yeah.
Oh, are in daycare. Right now, not a lot. I think 20%, maybe
20% are successfully daycare, same day, right? Same day discharge.
But I think,
morning or break.
Yeah, so if they are in daycare, a lot more are going home. I think we discharge 80% or something, but of the eligible patients just for bariatric surgery, I think right now 20% is eligible for daycare surgery.
And so for those in the overnight stay, do you have any like a high dependency stay, or even with the CPAP patients? What is your experience on that? Yeah.
If we have patients with a CPAP, they will stay overnight, one night on the intensive care unit, and then they go back to the normal unit. That's more just to observe them better, because we are very careful with the oxygenation of those patients. However, we see those patients sometimes do it very well, and it's not always necessary to go to the intensive care unit. However, it's protocolized in our hospital, so they all go for one night, because there is a better observation than just on the normal ward.
Yeah, thanks. So there's a few more questions. Do you have any criteria items prior entry in the fast track program, or all the patient enter systematically regard as of each? I think you answered that one, right? So you have some prior criteria you follow to which who will go to the fast track, who will be stay longer, right? This is a pre-selected. Yeah. Okay. Is there any standard protocol of the IV drip? Yeah. Yes, please, Eugene. Sorry for
I only wanted to say that almost all patients are going in the fast track protocol. Only if they had no primary surgery, even if it's a reintervention or something, sometimes they also can go into the fast track protocol. However, if it's a very big new surgery, then we observe them longer, but then they are not in a study.
So mainly is in your institution is most of the default is the fast track, right? Only for the very few people with some criteria will be given for the fast track. But in the study, this study, the 1,500 are all fast track patients, right? Yeah. Okay, is there a standard protocol of the IV drip rate and blood pressure control to make sure that those factors don't affect your threshold factors for sleep? Yeah.
So
Can you please address this
yeah,
question? Yeah.
yeah. The IV fluid after the operation, I think 10 years back, when patients came back from the surgery, they had a 2-liter IV fluid. However, later we knew that was too much, because if patient already can drink very good, we just give them 1 liter. But if it's really not possible for patients to drink water enough or something, then we give more. But most of the times they will manage. So we use 1 liter right now.
Thanks. I think there's one interesting question about any experience in the center about the remote monitoring in your institutions. That is interesting, because we are now more and more talking about the tele-monitoring, right? All the devices to monitor.
Oh yeah, so taking them home, the monitors.
Yes.
Yeah. There's a lot of discussion in daycare surgery. Sometimes it's used. However, sometimes the telemonitoring also finds the rates too late. So patients already have complaints before the telemonitor will see it. So the patient already has much pain or doesn't feel well and is already on the ER before the telemonitoring will detect some problems. I think the heart rate is the most sensitive one. So if you would use telemonitoring, I think giving them a monitor to monitor the heart rate, it's the most useful one. And we see that even some studies and hospitals, they don't give any telemonitoring anymore to the patients. They just give advice that if they have alarm symptoms, they have to come back.
I think since you have been doing this, I mean, you have been doing this fast track for some time, right? Is there any consideration about the distance of the patients, right, residents to the hospital? Because sometimes patient need to return, right? The emergency, the time is a golden hours. Is there any part of this you have been sort of consider in your checklist, right? The distance, or or so-called putting them in the fast track program. Yeah, thanks.
I think the Netherlands is a very small country, and there are a lot of hospitals performing bariatric surgery. So the rate of where the patient is living, the distance is, I think, very limited, very small. We have some patients that come. They have to drive with a car for like an hour and a half, but those are exceptional, because most patients, I think, live within a half hour from the hospital. But that's because in Holland, there are regions where a lot of people are living, and there are also a lot of hospitals. So you will go to the nearby hospital, and that's also probably the hospital where you're operated. However, for the patients which have to go further, you have to tell them if it's really a problem and they really have to go somewhere fast. Sometimes they have to go to the nearby hospital, and then it's not our hospital, but that's exceptional.
Good. Thanks. I think we share the same in Singapore as well. It's a small country, so I think the accessibility is not the big major issues. I think we can discuss more after this webinar as well. Okay, the other things I'm interested in is because you see there's a one checklist is a willingness, right? Willingness to be discharged. So let's say a patient say, I don't want to be discharged. And then the resident call the senior. Is this because you say that point is also one that the resident cannot discharge, right? Resident has to call the senior. Yeah. The senior say, okay, no other issues, the rest are okay, you can discharge, right? Is there any cohort of the patient with this not willingness to discharge, but it's discharge and then the minor complications or unplanned return to the hospital happen? And then is there any from the medical, legal, or complaints point of view, right? How is there any experience? That would be good for us to learn from your experience as well, I think.
Well, in our hospital, a lot of patients, if it's going well, they really want to go home. So if they are saying they don't want to go home, then there is something wrong, or they are not educated enough to know how to manage. They are just a little bit insecure. And most of the times you know when you're at the bed, you can see if it's do you not want to go home because you're in pain, then the patient is lying in bed and it's more passive, or is it just insecureness? And then you probably in the checklist you will see if a patient didn't had any oral intake like water or not mobilized and isn't want to go home, then probably there is something wrong. However, if just the only threshold is willingness not going home, then that's probably more insecureness. And we saw that a lot because you saw in the study patients that came back on the ER or at the outpatient clinic unplanned, they had more pain and they had no willingness to going home. But then it was more telling them how to manage their pain. So taking regularly your pain medication, don't stop it, because you saw a lot, then they just didn't took it anymore at home, and then they came back with pain. So it's more the before the operation to explain very good to them how it's working, what can happen after the operation.
So managing the patient expectations and then the well communication and education is very important to the successful fast track program.
Yeah.
So then the other thing I would like to check is that for those patients, right, who are having some difficulties, right, then how often do you contact them to rest assured, right, to make sure that they are well looked after in your program? That would be also interesting for us to learn to deliver a successful program. Yeah.
So we don't
Any follow-up call or
yeah. So not if we discharge them at day one, we will not call them the day after, but we will call them a week after. And most of the times we have a very dedicated team. So we have also some specialized nurses, and they will call the patients, and they are very specialized, so they know what to ask. And sometimes the patient has some normal questions, and the nurses can answer them. And if it's more specialized and the nurse is also a little bit doubting or thinking there's something wrong, they will call the doctor. But we do a checkup a week after the operation just to know if everything is okay. And then after 8 weeks, the patient will see the surgeon just to check up. And then after that, just once a year.
Yeah, thanks. Yeah, so I did a few more questions. I think I just noticed that. Okay, first is how long do the patients stay in the recovery ward before going to the normal ward? I think from the recovery post anesthesia care unit to the, is there any difference for the major complications of the patients? That is an interesting question.
That's a very good question. We didn't look at the time at the ward, the recovery ward. We did look at the time of surgery, because I think that's already also seen in the literature. If the surgery is taking longer, you have also longer sedation, so you sometimes have more problems. And if you give more sedation, you also will be probably longer at the recovery ward. So I think there's a connection. We didn't look at the time. However, I think most patients are very good awake after the surgery, because we give the lowest part of anesthesia. So they will we also have the rule that patients have to try to get over their own bed, instead of that we are doing that for them. So they are already very good awake. So most of the times after an hour, they will go back to their own unit. However, sometimes you see that the pain is not good manageable, and then they will still stay something longer. And those patients are the ones that will come back with more pain.
Okay, thanks. Yeah, I think I know you need to go by soon. So the two more questions I think from the participants. One is, how are the patients evaluated for OSA pre-operatively? Are all the patients evaluated routinely for those for OSA? Yeah.
So before the operation, patients come to the outpatient clinic, and they have a checkup like the ARAPS protocol. So they will see almost everyone: the dietist, the physical therapist, the surgeon, and only if there's a green light, they will proceed the surgery. However, if there's a problem, they have to just try to manage the problem with therapies, diets, and then they will get a green light.
And there's one more question: is the patient on the beta blockers? What would be the sign to count first, other than the heart rate? Do you have any experience on that? For those with the beta blockers, a beta blocker, then always heart rate will be still lower. I think in the paper is the median is still within less than 100, right? No tachycardia.
Yeah, I think, of course, it has an influence if they use beta blockers. However, still, if there is a complication and they have, for example, bleeding, the heart rate will raise. So it's still, even if they have beta blockers, you will see the complication. However, it's one of the risk factors having cardiovascular problems and using beta blockers. It's a, I think, familiar problem that those patients sometimes come later. The problem, you will see it later.
Yeah, thanks. I think before waiting for the formal question, I think that we have 7 minutes. I think probably I'll quickly ask you the one things I noticed in your study. By the way, for those audience, I think the Ifso has put up the link to everybody in the chat board, right? I think that's Stephanie. Stephanie has put up the article link in the chat, so you all can click on the link and then download the article as well. Okay, so my question to Dr. Judy is that in your study, most of them are sleeve gastrectomy, right? And then the RIGP and the OAGP, right? There's a lesser part. But I think number of complication wise, RIGP and OAGP has a higher compared to the sleeve gastrectomy. So I think, is there any difference between for them to do so-called daycare surgery in your experience for that such group of the patients who underwent for the RIGP and OAGP rather than the sleeve gastrectomy? Yeah, thanks.
Yeah, so in some parts of this country, they started only with the Roux-en-Y gastric bypass in daycare surgery. And of course, you probably have a higher chance on a leakage compared to a sleeve. However, the sleeve can give a higher rate of a bleeding. So that's a little bit deciding which you start with. And in our hospital, we started with the sleeve, because sometimes we use tranexamic acid to manage if we already think there can be a bleeding. So I think it doesn't really matter if you do a sleeve or a Roux-en-Y gastric bypass in daycare. However, you have to know which kind of complications are more seen, and you have to be more careful with that. So I don't think that it's a problem which one you use. However, in the study, you can see that there are more patients that receive the sleeve instead of the Roux-en-Y gastric bypass or one anesthetic gastric bypass. And I think that also explains the rate of the bleedings, because that was higher in this study. And also explains the lower rate of leakage, because that's more seen in the Roux-en-Y gastric bypass and the one anesthetic gastric bypass. And I think that's very interesting. I think if you want to look more carefully to that, we should do a bigger study just for those types of surgery.
Thanks, Judy. Yeah, I think before letting you go, I think the last one is the thanks for the congratulations again for the study. After this study you have conducted, right? So what will be the next stage to improve the checklist? Now is the negative predictive value is high, right? But positive predictive value is 7.1%, if I remember correctly. So in that case, one is a safer side is to keep calling the surgeons, right? But your high volume surgeons keep calling, then I'm not sure there's a communications, right? And the delay in the discharge as well, to some extent, if the surgeons are busy, or to reassess, right? So in that case, improving the checklist to some extent and the balance between that. Do you have any plans in the future to conduct any study for that? Yeah, thanks.
Yeah, so I think just also removing some parts that aren't very significant can already make it a better checklist, and you also get less calls, because you will not go over the threshold. And I think what we saw that you have at least need 3 thresholds before you reach the negative advice would also be an improvement, because still the negative predictive value would stay the same. So your positive predictive value would get higher, and that would be very nice for the surgeons, I think. So that's one of the things we can do. And putting probably the neutrophil to lymphocyte ratio in the checklist would be very helpful.
Thank you very much. I think since already we have 57 minutes, I think that we will probably close this webinar. Thanks again and congratulations. I'm looking forward to your further study and then being chosen as the best article again, so that hopefully I can interview you and then moderate for the session again. Okay, then before we end up the journal clubs, thanks all of you for participating. I think on October 19th, there will be a next Thursday, about 2 p.m. the same European time. It's about same time now. There will be what you missed in the World Ifso Congress. So we will be presenting about the best of the abstracts, which is being missed in the Ifso World Congress. Yeah, so all are welcome. Please look out for our Ifso Facebook and other social medias, as well as the Ifso websites for the details. We cordially invite all of you to join us again on October 19th. Thank you, Judith. Have a good day.
Thank you very
everyone.
much.
Bye-bye.
Bye.